Our speaker today runs just about everything when it comes to orthopedics and sports medicine, which is a very, very broad topic, I'm finding out. Sports medicine, to me, is a relatively new term, and as I age a bit, I like it a lot better than geriatric medicine, although I think maybe I have some other candidates in the audience. Chris Kaeding is the Judson Wilson Professor of Orthopedics at Ohio State, and he's the easy for me to say, Executive Director of OSU Sports Medicine, the Orthopedic Sports Medicine Fellowship Director, and Head Team Physician for the entire athletic department. He oversees a multidisciplinary program that involves not only clinical care, but a much broader research and educational program designed to benefit the university and the entire community. In fact, he's never been far from his passion for sports and fixing things, from his residency at Northwestern to his fellowship at the Cleveland Clinic working with high school, collegiate, and pro athletes. He also served as a team physician for the U.S. Olympic team. In 1991, a Buckeye was made when he helped establish the OSU Sports Medicine Center, and under his direction, the Sports Medicine Center has seen rapid growth in its breadth and depth, and as a matter of fact, on October 8th, Ohio State broke ground for the Jamison Crane Sports Medicine Institute, which is destined to become the top sports medicine operation in the entire nation. As you might imagine, he has been declared best doctor both locally and nationally, and he's no stranger to sport himself. If you catch him off the field or outside of the OR, he's backpacking, scuba diving, climbing mountains, or riding motorcycles with friends, which may be, no, he's not building up business with those motorcycle rides, I'm sure. But he's forever in a pursuit of a goal and a challenge. Would you please help me give a warm Rotary welcome to Dr. Christopher Kaeding.
Thanks, Dan, and CK and the rest of Rotarians to give me the opportunity to talk about something that's very dear and close to my heart, is sports medicine. So today, I thought we'd talk about, what is sports medicine, and I can give you the OSU perspective. Now, these are the four areas I'm going to talk about here, and I'm going to try to get this all done in the next 25 minutes. What is sports medicine Ohio State, what it means for you, and our vision for the future. Now, Dan was very kind in his comments, and I've been blessed that I'm the head team physician for the Buckeyes, and I became the head team physician in 2004. I was the orthopedic consultant in 91, so I've seen a lot of ball games. So what is sports medicine? Now, really, at its core, when people say, gee, Dr. Kaeding, how is sports medicine different than orthopedics? I'm taking care of a sprained ankle or whatever. Well, really, it's treating the injury in the context of the athletes. What are the priorities of athletes? What's the psyche of the athlete? What's the physical condition that we're dealing with? What's the priority of timing of the game, the season, or the career? So it varies. So it's personalized care. We are personalized that care of that sprained ankle or the shoulder, whatever it is, to that particular athlete's concerns and situation in life. So in sports medicine, we may give suboptimal care to an injury. I want to stop there so make sure I don't get misconstrued. We don't always give the best care for the injury because we want to give optimal care to the athlete. Now, what's an example of that? A sprained ankle. A basketball player sprains his ankle. What's the optimal care for that athlete, for that ankle? Well, it's probably immobilize an ankle for 4 to 6 weeks, like that ligament heal, and another 6 to 8 weeks of neuromuscular training, get all their muscles and reflexes and strength and endurance of the musculature around that ankle to recover. So you can tell that basketball player who's trained and made such a big part of his life, or maybe even self-identity, to play basketball, that you're out for 3 months because you sprained your ankle? No, we tape it up. We do what we can to allow them to get back to play because playing is of greatest importance to them. So we're giving optimal care to the athlete even though we're giving suboptimal care to that ankle sprain. So in maximizing the care of the individual, the challenge is we can alter the treatment of the injury to benefit the individual as a whole, but we must never risk the individual as a whole to return an injury to competition. So if you follow that. So that's the dynamic we get caught in. And we get pressure from various areas to do exactly what we don't want to do down here. And it can come from the athlete itself. The athlete to say, Doc, I can go, numb me up, give me a shot, shoot me up, whatever. I want to play, I want to play. Coaches can give you the pressure. Parents can give you the pressure. You can get pressure from all over the place. But we must always realize that this is what we need to do for those athletes. So in sports medicine, both the clinician and the patient function in this competitive arena of athletics. So everyone's trying to perform at a higher level to maximize their performance, run faster, jump higher, play faster. So what we learn from taking care of these athletes in the field, because we're pressured, no question. You go to Woody Hayes now, and I can guarantee as we speak, there's someone being pressured to perform at a higher level. Complacency is gone. No complacency. How can we do things better? Always getting pushed. How can we do things better? So a couple of little stories. When I first got here in the early 90s, a medial collateral ligament sprain of the knee, that's on the inside of your knee, if you had a complete MCL tear, you couldn't play, right? The knee's wobbly, it's loose. You can't send an athlete out there with a loose MCL, let him play. So we had, at that time, I won't mention his name, but he was described as the fastest linebacker in college football. This is the early 90s. And he had a grade 2 sprain of his MCL. It's kind of stretched out, It's a grade 2, we'll brace him, let him play. And then he hurts it. It's a 2.5, because if he's a 3, he can't play. So it's a 2.5. So he's still out there playing, and gets hurt again, comes off, we take a look at his knee, and now it's clearly a grade 3. It's a loose knee. And the other doc and I look at each other, well, that's it. He can't play. He's probably out 6-8 weeks. Fastest linebacker in college football, we just lost him for 6 weeks. So I'm watching the game. About 4 minutes later, there he is. Opposing player breaks free, and this guy runs like a deer from across the field, chases him down, makes a touchdown-saving tackle. Crowd erupts. I look at the other doc, the senior doc at the time. I'm a junior guy. I say, he can't play with a loose knee. You're right, he can't play. Did you see that play? I just saw him run. Are you going to tell Coach he can't play? I'm not telling Coach you tell Coach he can't play. Did you see what he just did? So we sit there kind of cringing, because the dogma at the time was, with a complete MCL, you can't play. And we realized that there's a small subset of the population, if you have what's called a varus thrust to your knee, you're not MCL dependent. You don't really need the MCL to do most things. So what we learned there, we now apply to everyone in this room if you come to me and have a particular problem with an MCL injury. So what is sports medicine? Personalized injury treatment we just talked about, dealing with medical issues such as asthma, nutrition, concussion, team management, drug testing, injury prevention, how you prevent injuries, rehabbing, trying to get someone who's had an injury or surgery back as fast as possible, as high a level or higher in as little time as possible. Injury risk assessment, pre-participation exams. At the professional levels, this is very big, where if you're the owner of a professional team and you're about to invest tens of millions of dollars in this athlete, you want to have an assessment for their musculoskeletal, their general health, and so you need sports medicine specialists to help you assess, gee, is this person going to perform, or is this person going to have a 1-year career or a 10-year career? And then performance enhancement. So that's the traditional view, but at sports medicine, we take a little bit of a different view. Now, I'll share one more quick story. The people say, gee, sports medicine must be pretty complex. And a lot of the things we deal with are very complex. It gets us complex because of psychosocial aspects of it. But other times, it's not quite so. I always like to tell this story. A couple of years back, we had a very fast athlete. In fact, he would go both ways. He was a starter on both sides of the ball. This is probably about 8 years ago. And it's about the 4th or 5th game of the season. It's getting to be a couple minutes for halftime. And there's our speed guy, and he's out there limping. He's limping around. Coaches are freaking out. What's wrong with, I'll call him Jerry. What's wrong with Jerry? Trainers, I don't know what's wrong with Jerry. I'm checking him at halftime. All right, we're going to run off the field. They got the clock going. We're in the locker room. It's halftime. We pull Jerry aside. What's going on, man? Foot hurts. Your foot hurts. Oh, yeah? Hey, what happened? Did someone step on your foot? No. Did you twist it? No. Then, 12 minutes. 12 minutes for the guys that have to run back in the field. Take your shoe off. Look out. Where's it hurt? Well, it kind of hurts over here. Is it tender here? No. 10 minutes. Going here. Well, you sure you can't remember when this started? Well, yeah, it always goes away. Jerry, what do you mean it always goes away? Well, I get it every week, but by Tuesday, it's gone. 8 minutes. I mean, every Tuesday it's gone. Yeah. How long has this been going on? Oh, months. A month or so. So it gets sore every Saturday, but by Tuesday practice it feels better, and then it gets sore the next Saturday? Yeah, I don't say anything because it goes away, but usually it doesn't get real bad until the 4th quarter. Now it's getting bad in the 2nd quarter. So let me get this right. So Jerry, 6 minutes. So Jerry, it only hurts during the game when you're wearing these shoes, and during the week you feel fine. Yeah, Doc, that's right. Hey, Doc, you think it's my game shoes? 2 minutes. We're like, oh, hey, I think we're onto something. We send a student trainer, get his practice shoes, put him in practice shoes. He puts them on. Hey, these feel great. He starts running around. We come out there. He's doing warm-ups, running like a gazelle again. The coach comes up. Doc, great job. Don't tell me what you had to do to get him going, but he looks great. So don't worry, Coach. It's top secret. It's trade secret. So it's not always as sophisticated as it always is. It seems to be. But at Ohio State, to win on and off the field, we feel that sports medicine is just not for the elite athletes, but for the athlete in all of us. So our mission at Ohio State is to improve people's lives by enhancing physical activity across the lifespan. So Hippocrates in 400 BC, he said, eating alone will not keep a man well. He must also take exercise. For food and exercise, while possessing opposite qualities, work together to produce health. So all this stuff about eat right and exercise, you know, they knew that 2,000 years ago. So I don't know how far us doctors have come. But exercise is medicine. We know that there's tremendous health benefits even to low levels of exercise. All right, so the second sentence here, the second line, this point here, the amount of exercise needed to benefit health is much lower than the amount needed for fitness. All right, so if you are here in this room, you say, yeah, I'm getting too old for this, it's exercise, and I'm never going to run a marathon in 3 hours or do this or that. The amount of exercise to improve your athletic performance may be this great. You may have to work this hard to improve your athletic performance. But you know what? You only need about this much exercise to improve your health. That's the beauty of this. There's been plenty of studies out there that are showing you are better off being 20 pounds overweight and exercising 5 days a week than starving yourself to a low percent body fat and not exercising. So you can be skinny and unfit, or you can be fat and fit. I like the first option, being a little extra weight, but I still try to exercise 4 or 5 days a week. We know that regular exercise can reduce the risk of heart disease by 40%, risk of stroke by 27%, diabetes by half, high blood pressure by 50%, recurrent breast cancer, colon cancer. You can keep going, all these, Alzheimer's, depression, all these things are benefited by exercise. So Bob Salas, he's the one who coined this phrase that exercise is a medicine or as medicine. And he's quoted saying, if we had a pill that gave all those benefits we just enumerated and was readily available, we'd find a way to make sure that every patient took it, right? So if I had this intervention, this pill that does all that benefit, everyone in this room said, yeah, give me that pill. Well, that pill is physical activity, 150 minutes a week. Just modest, just enough to kind of get your heart rate up. You can still have a conversation, you can still speak, just get your heart rate up, you're breathing a little faster. 30 minutes a day, 5 days a week, 150 minutes. What's the danger of that? Very little. So evidence is now overwhelming on the health benefit of physical activity, and that's what we want to do in sports medicine. We want to help keep everyone healthy and active, help everyone stay active across the lifespan. So we had a major organizational and conceptual restructuring at Ohio State many years ago, and what we did was, I like to say, we need to play to our strength. When the dean and the athletic director talked to me about assuming my current position a couple years ago, they said, Chris, what's your vision for OSU sports medicine? Well, here at Ohio State, we are the best preeminent sports medicine program in the country. What's your model? How are you going to do that? Well, here at Ohio State, there's one thing we are at Ohio State, we're big. The downside of being big is bureaucracy. Well, we can wrestle with that. But what's the advantage of being big? It's the breadth of our expertise. We have experts in just about anything and everything. Let's play to our strength. Let's start a multidisciplinary model, have a center, not place sports medicine in a single department. I'm an orthopedic surgeon, and we did some benchmarking. 80% of academic sports medicine programs are in the Department of Orthopedics. I realized here at Ohio State that would limit us. So we went to a center, and we have all these disciplines under one model of the umbrella of sports medicine at Ohio State. So you can see just in the last 8 years, success we've had at how many different areas, departments, colleges that we touch at Ohio State. So since 2005, we've hired all these personnel. And you can see some of our success right here, the growth in the last 10 years with this new model. And we're plateauing here a little bit because of physical space, and we're going to address that and mention that here in a second. Our physical therapy visits, our financial performance continues to improve. So winning on and off the field, a lot of it has to be innovative, right? You want to do the same things over and over again. So several types of innovation. One is organizational innovation. Now, one of the organizational innovations is that fact that we have this multidisciplinary model. Next. And the other is that our clinical care is also multidisciplinary clinical programs. We have a dance medicine program, we have a cycling medicine program, running, throwing, golf, ACL prevention, cardiac restoration, performance, hip preservation. These are all multidisciplinary clinical programs. So we take surgeons, non-surgeons, therapists, athletic trainers, research assistants, these masters in public health people, and we couple the clinical program with educational research programs. And that's, I think, one of the keys to our success with all these successful metrics you see. So what about clinical innovation? We were, this next little video seems to give me a lot of credit for it, but I'm not taking the credit. It's the system that now industry and people are coming to us, coming to Ohio State with some of these new technological innovations they want us to pursue. We had a big bang out of this Google Glass. So this Google Glass, and this is technology that's here. That was the very first surgery done with Google Glass, and it was we were able to telemedicine it across the internet. And what it is it's this hands-free, head-mounted interface where I can see this. It's like a rearview mirror. There's this little lens right here that they can send visual to you. You can send, there's a camera in it, you can send visual to someone else, and then there's auditory. In fact, it's kind of bone conduction. It sits here in your mastoid process, and you hear this voice in the middle of your head. But so they're able to send and receive both audio and video both ways, hands-free, all mounted on your head while you're working. It was very fascinating. So again, they came to Ohio State about us helping them pursue this. So that's fun. So innovation on the research side, that's the most obvious area that universities innovate is on research. And Tim Hewitt is our director of research, internationally known by the world's authority on the biomechanics of preventing ACL injuries. It took us several years to recruit him here. We just successfully retained him. Mayo Clinic went after him pretty hard just last month. And Tim's an exceptional guy. And you can see some of these, again, multidisciplinary connecting clinicians with researchers on a research program side. You can see he joined us about 4 years ago. You can see what's happened under his guidance, our externally funded projects, our federally funded NIH funding. This is when the federal government is funding less and less research. 90% of the academic institutions across the country, their NIH or federal funding research is dropping and ours is going up. Our participation in national and international meetings, look at this. So you can see here, 34 times we were at a national and national meeting on the podium giving presentations or moderating a session. Now you can see what's happened with our reputation and all that we've done in the last several years. It's just really taking off. Peer-reviewed research publications, again, 34 or 50, that'd be great. How many sports medicine centers in the country have 30, 40 peer-reviewed research publications in a given year? Not many. That alone is a very respectable number. But look where we're at, 140. I don't know if any other program in the country has that. In the last several years, 11 national research awards. This I can say. I can't imagine any other sports medicine academics in the country has won this many awards in the last 4 or 5 years or so. Media exposures. This is, again, how many times media is coming to us to ask us about, hey, what's going on with concussion, hamstring pulls, heat, et cetera. We're at 354. I had to put it down here because it just blows the scale away. A lot of that was because of the that Google Glass went viral. What about our outreach program? How about Central Ohio? How about the city of Columbus? And hands-on, how do we touch different areas? Well, we take care of USA Rugby. We take club rugby at the university, other club rugby teams. We also work with USA Rugby. In fact, rugby will be an Olympic sport in 2016, and the athletic trainer for the USA Rugby team, the USA Eagles, will be an OSU athletic trainer. So we take care of the Clippers. We can go through these, through our association of the Indians, Columbus City Schools. We take care of the Ohio Machine, Ballet Met, as well as the School of Dance at Ohio State, Columbus State. We take care of Capitol. We work very closely with the Special Olympics. They're very grateful. Our clinicians always enjoy working with this group of athletes. And then more recently, we work with Upper Arlington. So very engaged in the community. So what does all this mean for you? Well, if you, go ahead. If you need surgery for some kind of ligament work, or you need a cartilage restoration program, or you need some analysis of your golf swing because of recurrent injuries, or you have hip issues, you're trying to preserve your hip, whether you're a weekend warrior, you're trying to stay active as they get older, whether you're a captain or you're setting up a team, and how do I minimize injuries in my team, especially these young cutting sport teams. Maybe you're dealing with arthritis, and gee, I've got a particular joint that's bad and I want to stay active. Asthma issues, or you have concerns about concussion. Or you're a senior that just wants to stay active. Whatever the problem, whatever your age, we define sports medicine as a commitment to help you stay active across your lifespan, regardless of the problem. So our vision for the future at Ohio State, well, it's pretty simple. We want to be the best. We want to be the leading academic sports medicine program in the entire country. And Ohio State's uniquely situated to make this happen. I tell people, from my humble view of Columbus, I think there's a handful of things that Columbus has the potential to be a national leader in, and one of them is sports medicine. We have this innovative organizational structure we've talked about that very few academic centers have. I predict in the future everyone's going to be copying what we put together here. We have this tertiary care academic medical center. We have a preeminent athletic department. We have a very dynamic large land-grant research university, and we're in a large, attractive city. All these are touching each other, and what this does is it gives us a sustainable competitive advantage. Now think about it, Notre Dame doesn't have this, Penn State doesn't have this, Purdue doesn't have this. You go across a lot of our peers, and a lot of them don't have these pieces all juxtaposed, and we all have it right here. Believe me, to be a leader, you have to recruit, it's all about people, right? You have to recruit talent. Recruiting talent to Columbus, Ohio is a lot easier than West Lafayette or East Lansing or some of these other cities. So we have the ability to pursue this. So we need a new complex to house all these multidisciplinary programs, our educational clinical care, research, performance, and our surgical suites. We want all of these under one roof on the athletic campus. When this facility is complete, it'll be the largest, most comprehensive sports medicine facility in the country. We've benchmarked. We've been down to Jimmy Andrews, down to Pensacola. Went to about 6 or 8 different institutions across the country. Different pieces they'll have, but we're going to have all the pieces all under one roof right here at our brand new, we just broke ground last month on the Jameson Crane Sports Medicine Institute. So it's on the corner of 315 and Ackerman on the northwest corner of the athletic campus. So we're very excited that we can also leverage some of that brand to the Buckeyes. So I like to say people around the country expect OSU to have the premier sports medicine program, and let's not disappoint them. All right, thank you. So I went through that pretty quickly. I think we finished a few minutes early. Love to take any questions.
Hindsight's always 20/20, but if you look back on the first surgery that Braxton Miller had on the shoulder and then the second one, is there anything you might have done differently on the first one that would allow him to continue to play football?
So that's one of those, there's a lot of moving parts to the decision that was made at that time and in answering that question. And injuries in medicine, you know, everything in nature is a bell curve. I don't know any statisticians, the bell curve. And you can never quite predict with certainty how anything in nature is going to respond, any biologic unit, including the human body or a part of that body. So you have the option of, okay, we're going to go ultra conservative with this because in the bell curve, we want to capture the entire curve. So we're going to do XY surgery and it's going to take you 12 months to recover. Or we can come a little bit further away in the curve and capture most of the curve of success and try to get you back at, pick a time, 3, 4, 5 months. But now you're capturing less of that curve of success. So the more you push your plan this way, you gain time, but you lose a part of that success curve. So risk benefit, that analysis we wrestle with quite a bit. So if you'd gone on the totally conservative route, the season would have been over. You can go on a more aggressive route, and if that doesn't work, the season's over. But you at least have some chance of saving that season by pushing that decision-making on that bell curve here to the left.
Doctor, what are the implications of the lawsuit against the NFL over head injuries in football, and how will that affect the game in the future?
So we just here a half an hour ago, Donald Dunn just raised that same question. Let me repeat the question. The lawsuit against the NFL and about concussions, how that's going to affect what, football in the future or sports in the future? Very good question. No one knows. What's happened here is concussion has really grabbed the public's imagination. Parents are concerned about it. Legislators are aware of it. I got asked to speak by Joyce Beatty to a congressional panel a couple of months ago because Congress wants to hear all about it. Of course, people in Congress want to legislate a solution to this problem because that's what they want to do. They want to help the people. But there's so much we don't know about it. But you're exactly right. Depending on how society responds to this, potentially could this be the end of contact football, collision football? In one scenario, yeah, potentially it is. I think we need to know a lot more. In fact, what I told Congress is we need more funding for some quality research that's clinically applicable so we can answer some of these questions. We don't know who, if they do have a concussion, is likely to go on to this post-traumatic encephalopathy, you know, We don't want anyone to have concussions and then 30, 40 years later have this, dementia, this senile dementia. But clearly, most people get concussions, don't develop that. So who's at risk for it? Who is it? How do we measure it? How do we find out? Well, Johnny and Joe just had concussions. Ooh, Joe, you're showing the earliest signs of maybe that path toward the dementia. Your career is over. Joe, you show no signs of that. You can probably continue to play and not have a problem. Some people get concussions, some people don't. Probably the most famous OSU football player, without naming his name, says he never remembers ever having a concussion. Other people get concussed all the time. So, and there's some early evidence now, they're picking up a couple genes, there's a genetic predisposition. Everyone in this room has a different propensity to have some type of concussion. So who's at risk to get concussion? If you do get concussion, who's at risk to have this long-term sequelae? Is it, when are you fully recovered from a concussion? Right now, despite all this testing, you hear all about this stuff, about web-based testing and neuropsych eval and all this type of stuff. None of it has been shown to be any better than a knowledgeable healthcare provider who knows the athlete, kind of doing the old, yeah, Jimmy, I think you're okay. Or you're acting funny, looking funny, or you're back to normal. So they're trying to quantify that because the athletes aren't always honest with you. They try to fool you because they want to get back playing. So when are they recovered? What's the fastest way to get them to recover? And is there a way to protect them in the future so they get a subsequent concussion? So those are some very fundamental questions we need answers to before we start going, football's banned. More people get concussed from playing soccer than football across the country. More people get concussions falling off a bike than playing football. No, it's to do with banned bicycles. I mean, you have to sit and think this through before you get too knee-jerk on it.
If you have a elite, in my case, granddaughter athlete, she's a ballet dancer, what age should she be evaluated for the exercise program?
So
she's 11 now, just as an example.
Yeah, we'll see. I think once they get to be 10, 12, we have the expertise to help take care of them. And you want to assess, and that's another part of our research, is how do you take that young, committed, the question there was a dancer, ballet dancer, 11 years old, very committed dancing, I suspect, and as a parent or a family member, you want to, I'd love for them to have a great dancing career. How do we minimize these injuries that can end careers? So assessing them, doing these functional movement screens, how do we identify for you, each individual, you have a risk for a shoulder problem, you have a risk for a knee problem or a hip problem, or you have the earliest signs of this particular problem. Let's do some modifications to prolong your career and minimize progression of that particular problem. That's that preventive, personalized healthcare that we're pursuing, we're learning more about, and that's Tim Hewitt's expertise, so trying to identify the risk factors for any particular injury and then personalizing it for you.
I've been around a long time, even a year longer than your Jim Crane year. And I've never seen an athletic team get bit as badly by the same thing as the women's basketball team. Is that pure freak or any indication they're doing something they shouldn't be or not doing something they should?
And you're right, these injuries tend to run in cycles. I'll come back to the women's basketball. I'll give you examples with football. I've been with the football team since '91. We'll go a couple of years not have much low back pain. And also we have a year with 2 or 3 or 4 guys having back spasms. They throw their back out, did this, and coaches going crazy. And then you have to watch out. The dynamic is you want the coaches blaming the strength conditioning, who's blaming the trainers, who blame the docs, the blocks. You don't want that. You want to avoid that blame game. You have to work together, maintain that integral work team concept. But then the question is, why do all of a sudden 3 of the guys can't have back spasms? We haven't had a back, or hamstrings. Okay, literally, we just had 4 guys with hamstrings the last 3 weeks, and we haven't had a hamstring for years. So we do look into that when it does happen. And as I just mentioned, it's always dynamic, right? You always have new coaches, new coaching techniques, new strength and conditioning thing, new practice. And the coaches say, I just came back from whatever, the Philadelphia 76ers, and we're going to start doing this with our people. And every benefit has a cost, and is that cost and increased risks? And then trying to sort out what has changed to put them at risk, or is it just a statistical blip? So your question is, can you always identify something? Is it always something that's changed, or is it just a statistical blip? The answer is a little bit of both. The challenge is to try to sort out, and trying to document and show cause and effect is always very tricky. All of a sudden you got 3 ACL tears on the women's basketball team, and someone says, you know what? They just changed to putting pizza on the training table. It's the pizza that did it. Well, obviously that's not the pizza, but you could also say, gee, it's that new exercise they're doing in the training room that's doing it. Well, maybe not. Maybe that's just pizza. Changing the diet. So trying to find a concrete. By the time you start chasing it, all of a sudden the ACL, that little blip goes away. You don't have them anymore. So it is an ongoing challenge, and it drives coaches a little bit crazy. Yes?
Yes, 2 quick questions. One, common is it for athletic trainers to inject athletes these days with cortisone at the college level to help them get through a game or that kind of thing?
So you ask, how common is it that we do injections? You ask athletic trainers do injections. Athletic trainers do not do injections. It would be the physician. So I'm very proud here in our state, we inject very few injuries, all right? And it goes back to those couple slides about giving suboptimal treatment for the injury to give optimal treatment to the athlete without putting that athlete at long-term permanent risk for other, sequelae. So cortisone is very rarely injected in joints anymore. That was done commonly in the 50s and 60s. It looked like a miracle drug because it would make that sore, swollen, inflamed joint feel so much better. But they also started realizing that repeated use of cortisone actually accelerated the degeneration of that joint. So we rarely inject cortisone into a joint. How often do we numb something up? Again, compared to my colleagues across the country, very, very little. With the football team, I can probably count on one hand how often we would do that in a season. So it is not like, oh my goodness, we're shooting all these guys up for every game. It would just be a handful of guys over the course of an entire year.
Thank you. I was actually thinking in terms of a couple of weeks ago, there was a key player injured a knee, and then over time he just performed like he was never injured, and maybe just gutted it out. But so I'm just curious about that. Second thing is, since we now can identify athletes who are predisposed to, for example, knee injuries, MCL, ACL, at some point in time, will the physicals that athletes need to pass to play include some kind of an analysis of that?
So that's a very insightful question. That's going to be a societal issue. So you can say, gee, is this going to happen at the college level? Is it going to happen at the pro level? Is it going to happen at the industry level, the industrial athlete? As we identify the genes or proteonic profile, draw your blood, look at the serum profile of some of the proteins in your blood, we can say, you know what, this person has a high risk for getting tendinitis, stress fractures, rotator cuff tears, all that, the mesenchymal system, the musculoskeletal system, they have an increased risk for that breaking down. So if you own a coal mining company, hard physical labor, you may say, I'm not going to hire this guy if you tell me he's got XYZ genetic profile because he's going to break down and get a workman's comp claim. So do we want to do that as a society? Do we want to screen people for jobs depending on their genetic predisposition? Does that happen at the pro level? Will it happen? I'm guessing the first place it may happen maybe at the pro level, where they'll draw some blood and do some testing and get a sense for how durable, how likely you are to stay healthy for the next 5-10 years. But as you think about that, it leads to a lot of different societal issues.
At least here in northern states, the high schools have become standardized on artificial turf. Have you noticed a change of either more or less knee injuries? And then on a kind of a side question on there, do you even look at, is there enough statistical concern over the carcinogenic effect of the chewed up tires that seed those fields?
Yeah, so a two-part question. I'll answer the second part first because that's pretty straightforward. There's some concern about it because there seems to be some association about these artificial turf and then the, it was lacrosse, right? Lacrosse players, female lacrosse players having this incident of cancers, and it was in the goalies who get more down into that turf because they're down on their knees and falling and getting sprayed with this stuff more commonly. But there's never been any evidence of scientific validity that's shown that. But you're right, you start off with some kind of observation and then you need to dig deeper. And some people have over-responded to that and media loves that type of stuff. But there's some area of concern needs to be looked into, but there's no evidence about that. Artificial turf and injuries. It's not necessarily the surface you're playing on, it's the shoe surface interface. The more that shoe has great ability to grab, has a high coefficient of friction, the more likely you have an injury. For example, we see very few knee injuries or ankle injuries in mud. If it's a rain and it's mud and the guys slop around, the feet are slipping, they don't have much. When they came up with this artificial turf and guys started wearing spikes, because the athlete goes, man, this is great, look at my traction, I can make a really hard cut because my foot doesn't slip at all. That force, if you look at the biomechanics, look at some of the stuff from Tim Hewitt's lab, you'll see these big force spikes that go up the extremity. Just having the foot slip about an inch when they make that cut, the athlete still perceives they can perform at a high level, but because the foot slips an inch on that grass or turf or wooden floor, whatever it is, you decrease those forces. If it's like Velcro and it doesn't slide an inch, it slides a 0.5 millimeter, these loads go way up. So it's the shoe that you wear that should match the surface. That's my own opinion. So, in fact, Nike had a shoe, it was called the Destroyer. And sure enough, it had big spikes for artificial turf, and it was destroying his knees. Well, they pulled that off, didn't talk about it anymore. So the athletes like traction because they can perform better, but we actually did a study trying to find that perfect coefficient of friction where it's high enough they can perform, but low enough the foot slides a little bit. It's like you don't see that many injuries in ice hockey except for collisions. Because what's a fast, abrupt stop in ice hockey? What, 6 inches? You know, they cut they skate and they slide, you know, so that's, again, the forces are diminished if you can spread them over a relatively short period of time.
Last question, I think we have one.
For the people in this room, and let's just assume a median age of 55 and good cardiovascular health, what's the best activity when you have limited time to get that amount of exercise you were talking about? Walking, running, bicycling, swimming?
Best question to end the day on. I'll repeat the question. He says if you're 55, which in my opinion means you're just about ready to peak, and you're in reasonably good health, but you're 55 and you've taken some of this talk to heart and you want to get in your 150 minutes a week exercise, he asked, what's the best exercise? Well, here's my response to that. You want to get your heart rate up to a conversational level, meaning, okay, you're breathing a little heavier, and your heart rate's up, but you can still have a conversation. If you're breathing so hard you can't have a conversation, that's okay, but you don't need to be at that level. All right? So you got your heart rate up a little bit. You need to do something that doesn't cause you to be sore the next day. If you've got a couple sore knees from whatever, your high school football days, and you're going to start walking, and the next day your knees are sore because you did walking, well, I wouldn't walk. All right, so if you've got a particular joint ailment and you're sore the next day, you shouldn't do that. So maybe you should swim or maybe you should cycle. Third part of this whole thing, do something you enjoy. Don't make it a chore. If you absolutely hate jogging, but I got to jog to make myself healthy, but you'd rather go to the gym and do on a rowing machine or a stair climber or elliptical or something, then do that. Do something you enjoy. A lot of people, if you do it, especially the women, if they do it with a girlfriend and they meet, 3 days a week, whatever, now it's a kind of a social thing. They do it and they're kind of committed to doing it. So do something that you know yourself, be honest with yourself. Is this something I'm going to do every week for the next 10 years, or is this something I'm just going to do for a couple weeks and get tired and quit? So do something you enjoy doing. All right, thanks a lot.
Doctor, there's nothing personal, but I hope I won't come to you for operations. That being said, this is a gift from Argo and Laney for that was a very interesting topic.
Thank you very much.
Thank you. Thank you.